I'm just going to give indication for Belle to start the... Yeah, thank you. Morning, everyone, and welcome to the Birmingham Health and Wellbeing Board. I'd like to start off by just advising members that this meeting will be webcast for live or subsequent broadcast via the Council's meeting YouTube site, and that members of the press or public may record and take photographs except where there are any confidential or exempt items. And the next item is any declarations of interest. Just to remind members that they declare all relevant pecuniary and non-pecuniary interests arising from business to be discussed at this meeting. Does anyone have anything to declare? Yep, Justin?
Yeah, just to let board members know, I've been successfully appointed to the board of the Food Standards Agency. So I've taken up that as an additional role outside of my council role.
Thank you, and congratulations.
Thank you.
My husband, Dr. Ed Day, co-wrote the Dame Carol Black drug strategy.
Okay.
Which is probably relevant.
Relevant to item 13. Mm. Thank you. Any other declarations of interest? No? Okay. Any apologies?
Through Chair. Apologies received from Mark Garrick, Sue Harrison, David Melbourne, and Claire Day will be attending on his behalf, and Asha Mohammed and Riaz Khan will be attending on behalf of the DWP.
Okay.
Although I can't see her.
I'm sure they'll work out how to get into the building is probably the first task. Thank you. And then the next item is just to note the date of the next meeting, which is the 28th of March, starting at 10 o'clock. And the next one is minutes of the last meeting, which was on the 29th of November, and it's just to confirm and sign the minutes, unless anyone's got any comments. Yes, Councillor Bennett.
Yes, it's not about the accuracy of the minutes, but they do correctly say that I raised the issue of MRI jabs vaccinations last time. It was my concerns were noted, but I do recall that you did give an undertaking that it would appear on the forward plan. It still doesn't. It's not on the agenda item today. When in past meetings, all elected members, your predecessor and Councillor McCarthy's predecessor and myself all expressed concern at the sort of what came across as a bit of complaint. There was some alarming reports about the data in the press in October, and since then we haven't had it discussed at this meeting, so I would like to see that appear on the agenda.
Thank you. Firstly, I'd like to apologise that hasn't happened yet, and I wasn't able to have a conversation with you to just inform you, and it makes sense to inform the rest of the members of this meeting that an update around vaccinations will be going to HOSC on the 21st of March.
23rd. Yeah.
So it will be going in the next sort of few, within the next 2 months to, is it March or February? February. Apologies. So it is in the next few weeks. Yeah, so it will be going to that meeting, and so sort of in discussion and planning the meetings for Health and Wellbeing Board, rather than the same or similar sort of update come to a public forum. The suggestion that I've got to bring today is to see whether we put it onto a meeting after. So the next one we've got, I mean, potentially it could come to March if you'd like it still come to Health and Wellbeing Board, but otherwise, in terms of just making sure that we have some sort of different data and information coming, and it's not just a repeat of sort of similar information coming in a short sort of similar sort of time frame. That was just a discussion point for members to see whether they would prefer it to still come sort of fairly close, 4 weeks apart to this forum.
Personally, I don't particularly mind when it comes as long as it comes.
Yeah.
If it's acceptable to the member, what we could do is append the HOSC discussion presentations for information item for the March meeting. Mary OOS joining us online at MyID for Health Protection, Environmental Public Health and Update. It's going to HOSC in February and April. And this has been in discussion with the HOSC committee around the desire to ask NHS Midlands and the ICS for update on the response.
Okay, that's great.
Yeah. Okay. Thank you. Anybody else got any comments on the notes for the minutes of the previous meeting? No. Are they agreed? Thank you. And the next item is just the action log. Does Aidan, did you want to run through the action log?
No outstanding actions.
Okay. So this sort of just leads me on to just giving a bit of a chair's update. And since the last time that we met in November, I mean, quite a lot has happened. Obviously, we've had the sort of peak winter period, as well as a focus in the media on UHB. And I'm pleased to say that if David was here, that David would have been able to confirm, that Claire is able to confirm that swift action was taken to move Dame Eve Buckland across into the role of interim chair at the Trust to help provide stability at this time. And in place of Eve Buckland, Patrick Vernon moved across to cover the vacancy left by Eve as chair of the ICB in the meantime. In terms of any sort of involvement that's happened from a council perspective in relation to the reviews that have been taking place around UHB, a cross-party review group, reference group has been established, which is chaired by Preet Gill MP, and the first meeting took place last week, and the second one is scheduled for next week. And as chair of the Health and Wellbeing Board, I sit on that as well in this capacity. As we know, obviously, as I mentioned, the winter pressures on the health system are always extremely tough. And during the cost of living crisis, even more so as people struggle with the cold and illnesses that have been going around. Despite the situation, I was pleased when David Melbourne put on record his thanks to the adult social care team led by Professor Graham Betts for the work that they've been doing to help keep the discharges from hospital flowing and ease what might have been a much more difficult situation all around. I also put on record my thanks to David, Eve and Jonathan Brotherton for kindly offering and attending 2 separate briefing sessions for elected members to put their questions to them openly around the situation at UHB, and similarly to Graham Betts and Andrew Marsh within Adult Social Care for the session that they ran for elected members on hospital discharges, giving an opportunity for members to be able to ask questions directly around the situation and how we're supporting the NHS during this winter pressures. In other updates, the Black Ear Implementation Board has met and continues to meet and are in the process of appointing an independent chair. And until then, I've been chairing that board, and we've already started work on looking at the opportunities for action raised in that review. That's I mean, I could keep going on and telling you lots of other things that have happened since November, but I think I'll end there and then continue with the rest of the meeting. So the next item is public questions, and I don't think that we've received any. No. This moves us on to item 9, which is the cost of living crisis. And as you know, in the last meeting, we had an update from Greg Ward around the council's response, and I thought it makes sense for us to have another update to see how things have been progressing since the last time we've met. And Greg has joined us online, so I'd like Greg to present this item. And as always, if you can just indicate if you've got any questions, and we'll take them at the end of this item. Greg.
Thank you, Chair. Can I just share a slide with you, just an update slide? It's just one, just to give you some of the information on what we've been doing to date. Can everyone see that?
I mean, I can't, but I'm sitting furthest away, so I don't know if anyone else can see it better.
Shall I just present on it?
Oh, there's an echo.
Hello?
Yes, Greg, we can see the screen.
Okay, so since the last meeting, these are the general updates. We now have 142 warm spaces which are open across the city, and I do need to emphasise that when I say we, it's a very strong partnership. A lot of different partners with warm spaces that are in our own assets, such as libraries and leisure centres, but also in a museum. We've got food pantries that are acting as warm spaces. We have faith centres, and we even have a bowls club that's acting as a warm space. So quite a significant number of people have come forward to support these, and it's great to see the diversity that we're getting, and many of them are catering for different communities within Birmingham as well. We've launched a grants scheme, and we've had 113 applications for large grants. These are grants of up to £10,000, and they're for the very large spaces to allow them to buy furniture, or to redo up a room, or to provide crockery and kettles and things like that. And then we have applications for micro grants, which is the smaller spaces, for grants of up to £500. And the details for both of those schemes can be found on the Birmingham website. We're also got emerging plans for the co-location of services. So we're looking at how we can use these warm spaces, not just to provide warmth, but very much in the spirit of ensuring that we're not stigmatizing people, that we're creating welcoming places where there's a lot of socializing that goes on, but also opportunities to provide information and advice and guidance, to help people with their mental health issues and so forth. So these spaces, as a network, are developing into a very innovative set of partners, helping us across the city with a number of different elements. And one of the most interesting areas is that we have had some approaches from cultural organisations asking if they could perhaps use them as creative spaces as well, particularly helping perhaps younger people with creative projects and so forth. We have had 100 applications to for our food banks, and we're providing monthly payments to 100 organisations of £800 over 6 months. We have approximately 130 food projects in total, of which 100 are now being supported over the winter. But we have had approaches from a number of other organisations that haven't been registered with the Food Justice Network, and we're in dialogue with them about how we might look to help them as well. We've supported the Holiday Activities and Food for Children fund over the Christmas holidays, matching DFE and producing some 30,000 meals for children and their families. And we're supporting 14 of the major youth centres in Birmingham to help buy new cooking equipment. They cook for young people and produce about 75,000 meals every year. One of the most promising areas has been in advice and support on income maximisation. So the neighbourhood offices have extended their opening hours by 5.5 hours, increased telephony and face-to-face capacity. And for what was quite a small amount of outlay of investment for us, this has produced a total income maximisation during those increased hours of over £500,000 since the 1st of November. So these were benefits that were not being claimed by citizens, which are now being claimed. And some of the settlements have been quite life-changing. We had one family that were entitled to over £10,000 worth of new benefits per year. And then a further increase of advice is planned through community organisation grants, and we hope that will create about £2.5 million in new benefits for vulnerable Birmingham residents. And then the contact centre is making an additional 1,000 calls a week on average. Finally, in terms of energy, we have energy vouchers which have been approved for between 4,000 and 5,000 homes, many with prepayment meters, and that's being distributed through the local welfare provision team. And that's where we are to date.
Thank you, Greg. Can I just check to see if anyone's got any questions or comments on what you've presented in relation to the update so far? Don't have any indications. I guess that just means that everyone's satisfied with the information that you have given. And as always, if anyone does have any questions outside of this meeting in relation to any aspects of what the council's response is with the cost of living, then please do get in touch, and we can circulate any information that you can share with people within your organisations as well outside of this meeting. Thank you once again, Greg.
Thank you, Chair.
Next item, item 10, running along with the same theme of the cost of living crisis. I'd like to bring in Stephen to present the Insights report on behalf of Birmingham Voluntary Services Council. People should have received the report already, and I think that you might have a presentation as well to support it. Yeah. Brilliant.
Okay. So the report has been circulated. It's actually a draft version because it was just prior to publication that the meeting papers came out. That we now have a finalised version. It's almost exactly the same, but I'll ensure the link will be sent to that. The report was constructed out of a cost of living event. You can see a picture of there that was in the priory rooms, which was primarily a workforce engagement with the voluntary and community sector talking about challenges. It was in the latter part of last year, and there has been significant progress since then, both in terms of some of the actions, but also in terms of Birmingham City Council's response. I know when I initially asked for a slot here, I was expecting to have to come and talk about the systemic challenges that we were facing as a city. I have to say, there is very little noise in the system around the city's response to this. By and large, I think the view has been that it's been really positive, that the way that the city has worked and the way that Greg and Richard and the team and public health and all of the different parts of the council have worked has been really positive. There are, of course, it covers a huge amount of ground. There are associated challenges with demand pressures, waiting times for different services, those kind of things. But the core of the cost of living response has been very positive. That's not to say that we've mitigated all of the impact on citizens, because obviously this is a very significant challenge. I won't go through all of the details of the report. I'll just put them towards the BBSC website, where there is an overview of the report, and there is also a cost of living toolkit for organisation. In terms of the action report finding, the core things are what have been determined previously. The crisis is worsening existing inequalities within Birmingham. Birmingham's VC FSE capacity is at breaking point, and that's not to say that sector organisations are on the brink of falling over, although everyone is dealing with increased cost pressures. One of the significant challenges that they're facing is just the number of people coming through the door is much more increased, and that's very difficult for the organisations. There is certainly a challenge around sector workers who are paid less than the real living wage. There's lots of support, lots of very significant support that's being. There's a real issue around the sector's capacity to step in and step up. We're still struggling after the pandemic and has been asked to step up again, and has done so. But we need to be mindful that if we keep facing an emergency situation, the cracks will start to show in the provision. In terms of recommendations, so there are 6 sets of recommendations around collaboration and funding. BBSC will take lots of these forward, although they do involve lots of other partners as well, and lots of them have come into place. So, for example, around funding, Greg just mentioned the food banks and the warm up resource. That we are connecting funders with voluntary sector organisations who are working around cost of living. There is activity to support volunteering and workforce, and there is also importantly we're promoting Birmingham as a living wage city, which I know that is a city council priority. In the paper that came around with this, one of the requests is that, especially where you're leading organisations that commission voluntary sector organisations, if you push around price all of the time for your activity, that often falls into challenges around wages. And it is no good our voluntary sector organisations supporting people only for their staff to have to go to the food banks at the end of the day. And that isn't an uncommon experience. Certainly the food banks across Birmingham do have voluntary sector and statutory sector staff within them looking for food for their families. The other recommendations that I won't go through all of them, was centrally around focusing on prevention in terms of strategy, and then also that we need action around crime in the community. And I think critically one of the spaces, although we're still looking at that, the risk of loan sharks moving into spaces where people are particularly vulnerable is significant. More than taking that forward. Lots of this, as I said, this was at the end of November. Lots of this has been taken forward, and we'll be contacting partners asking them for support on various items. I would just like to draw your attention. There is a staff health and wellbeing event on the 13th of February, which is to look at how we support voluntary sector workforce across the city. Be very pleased if you could promote it to the voluntary sector organisations that you commission, and if you would like to attend, you'd be very welcome.
Thank you, Stephen, for your update. Can I just ask, before I check if members have got any questions or comments, if it'd be possible to get the information for that staff health and wellbeing event circulated? You can send it to us and we can make sure that everybody receives that. Does anyone have any questions or comments on? I'm so sorry, I can't see you. Okay, hi, can I bring you in?
Yeah, I just wanted to thank you for the report. It was really interesting and certainly very reflective of our experience in cyber over the years. Something that I wanted to just add in, which I think the report doesn't mention specifically, in terms of the board here today, is there was an article in the Guardian out yesterday around the impact of cost of living. Research that was done by Homeless Link, both membership bodies for homeless and also housing providers and homeless charities and housing providers. They were saying that over the next few months, 50% of services are considered closures because of the impact of cost of living, both on the cost of providing their services, also providing some of their accommodation. So I just think that whilst we know there's a lot of good work happening in Birmingham, I think Stephen's right, we can't get complacent and think that these challenges are going to be and I think through the work that BDSC are doing and the continued relationship with the sector, it's really important that we early service closures at a time when the capacity is through the roof. And aside from we're not immune from this, but we're certainly going through the same challenges because the costs of providing services are getting to a point where we can't continue to do everything now. So I just wanted to take the opportunity to flag that.
Okay, yeah, Justin.
Yeah, and I think it's a really important point. And as some colleagues were on the cost of living partnership group chair yesterday, and Richard Brooks, who leads the response work on behalf of the council, has said that he's coming back to the next meeting to discuss the emerging thinking. There's a very clear recognition, council, this is not one and done. This is not a short-term situation. Actually, what it's creating is a significant shift across the city, and we need to have a long-term strategy around that. So some of that is around job creation, but some of it's around job salvation in essence. So will be continuing an ongoing conversation, I think, through that group.
Thank you, Steve.
Just to raise that a number of commissioning and grant giving organisations have given uplift largely against salaries, but it takes quite a long time for them to decide how to undertake that activity. So I know Cycle have done this, but for voluntary sector organisations, if you can encourage them to talk to their funders as early as possible, in order for them to be able to think about whether there's a possibility of an uplift against their activity. I have to say that the City Council, but also the grant and trust funders, have been very responsive to the idea that the grants need to be read.
I'm going to come back on this point, but yeah, that's fine, and then I'll bring you in.
Yeah, I completely agree, and actually we've had some really positive conversations with Birmingham with council and our commission's work, so I would definitely encourage that. I suppose the charities that we're working with is the self-funded activity that's really at risk, and this is due to a large decrease in public and individual donations to charities at this time. So actually a lot of our commission services will be okay, but it's the other things that will be prop up within the city through our self-funded activity that are more at risk.
Thank you. Peter.
That's just to update really from a Birmingham Social Housing Partnership point of view. We had a practitioners meeting a couple of weeks ago, which was really helpful in just, I think, concurring with some of the things that have been said in the presentations of how helpful the city strategy has been in linking people together. Practitioners across the housing association sector were saying they're finding their customers and tenants, the access to warm hubs, the access to grants and so on has been really helpful. On one hand, really reassuring is that the commitment not to be evicting anybody as a consequence of poverty is holding up strong, I think, in general needs housing for housing associations through a lot of the preventative work that's happened. The worrying side was, though, is that the sort of sense of practitioners working right on the front line is we haven't got anywhere near the sort of real problem yet. People are still just holding in, both in terms of living conditions, people in sort of very cold circumstances where they just can't switch the heating on, just about managing. And so it almost still felt like a law of the sort of calm before the storm, which being in January, you'd sort of think we'd see a little bit more. But I think that really concurs with that long-term message, but sort of long-term partnership as well that we see. So just to give that little bit of feedback, I think positive. Homelessness, I think, is still being presented, at least from the general needs point of view. But sorry to be corny, we haven't seen anything yet, I think was the summary of what practitioners were saying.
Thank you. I wanted to just come in relation to one of the recommendations, Stephen, around workforce and volunteering. I know that BVSC held the Vision for Volunteering event, which I think was a really good opportunity to bring voluntary sector organisations together and be able to work towards discussing on a strategic level how we see the vision for volunteering across the city. And I think going back to one of the points that you made in your presentation around how we're almost expecting based on circumstances beyond our control, where the voluntary sector and voluntary organisations and therefore volunteers have had to operate in an emergency mode and really sort of stepped up across the city when it came to the COVID crisis, and then are now during winter pressures almost kind of have had that experience, and then there's some level of onus on them to similarly step up and support the organisations and citizens across the city based on what's happening around cost of living and winter pressures. Except the difference here, and that was one of the things that were picked up at that event, was that during COVID, it meant that the situation was such that lots of people, due to the restrictions, were able to go out and help because they had that time available. So if they were not at work because of lockdowns and they weren't able to work from home based on whatever sector that their usual sort of day-to-day job role was in, they had that availability to be able to help out and support. In this situation with the cost of living, the difference is that they don't have that, and actually, despite going to work, not having that spare time, not being able to afford, based on the crisis around energy and everything else that's going on, it just means there's a lot more pressure. So although the voluntary sector and the volunteers are still there, trying their best to be able to help, that strategic thinking needs to be thought across the city, where we see that the different circumstances, despite if it's an emergency measure, but depending on the circumstances, it won't necessarily be reflected over. So that was just a point in reference to the recommendation section, just to bring up that it was a really good opportunity, and that was I attended that. It was a good event to be able to hear from people and see how they see what volunteering should look like and the different roles that it can be played across different organisations and sectors in the city. But that was just a sort of thought that we do sort of see that we're in crisis mode and then we're in crisis mode again. But that thinking needs to be done so that the voluntary sector doesn't have to feel that the pressure is on them to operate in that crisis mode, because it's not possible in a situation like this. Does anybody else have any questions or comments on this item? No. Thank you so much for bringing this presentation and going through the report for us. I'd like to, again, we're on the same theme of the cost of living emergency. Thank you, Stephen. I'd like to bring in Andy from Birmingham Health Watch, who will be doing a presentation on the cost of living as well. And do you have a presentation on the screen that you're pulling up?
I'm particularly trying to get it up onto the screen.
Thank you.
So apologies that this hasn't come out in the pack yet. I will forward the presentation because it's got a lot of stats in there. Because this is a live survey that we've currently got open, I pulled off the data last night, so you've got the most up-to-date statistics within this. So what I wanted to do is just update two sides of our organisation, really. One, what we're doing to help and support people connect to the information they need to get through the cost of living crisis. And also what we're doing around understanding people's needs when it comes to health and social care in relation to the cost of living crisis. So going back to October now, our information and signposting service did a big mapping exercise to understand the support available for people, connecting in all of the different directories that exist within the city and connecting to Birmingham City Council's directory around cost of living as well. So citizens can access that via the telephone, online, via face-to-face community engagement as well. So there's a lot of ways to access this, and it contains information on there around managing finances, heating and housing, food, mental health, all the key areas around the cost of living to make sure people are accessing the help and support that they need. In the last few months up to the end of December, from October, 1,249 individuals access those pages on our website as well. So they are being well used across that, and the links there to our website. If you have people that you come across that need additional help and support, please signpost them to us as an organisation. It's not just that health and social care element, but we can do the more holistic signposting to get people the help and support that they need. So when it comes to understanding people's experiences in Birmingham, we launched a survey back in December, now on the 19th of December. The survey aims to understand the impact of cost of living on health and well-being and whether it's affected how individuals use health and social care services specifically. We deliberately took part in the National England survey from Health Watch England, developed by them, which means that we can have some comparison from a local level to what's being found at a national level as well. So we can have an understanding of how local residents compare to the national survey. The national survey is currently based on 2,000 adults across England between October and December, with the latest findings coming out early January, around December. And I've done the comparisons for December within that survey, within this presentation. So from our survey, it's a Birmingham and Solihull survey. We've done it across both sites, but I've pulled out some of the Birmingham specific data for this presentation. So 299 people have taken part, with 191 individuals from Birmingham within that. The people that have taken part in the survey now, 62% of respondents said that they're not financially comfortable. What that actually means is they just have enough money to cover their bills or worse. So they're struggling to cover those day-to-day bills, and that's 61% in Birmingham. And so, not surprisingly, 77%, so 3/4 of people have said this financial situation has got worse in the last 6 months. When it comes to health and well-being, though, 2/3 of individuals have reported that their physical health has got worse in the last 2 months, and 67% have said that their mental health has got worse in the last 2 months as well. And actually, that goes up to 71% in Birmingham when we separate out the data. Mental health is significantly coming out much higher in Birmingham from our data. The national level is around 35% that's being reported by Health Watch England. So something to consider there. In terms of some of the overarching cost of living areas, so around isolation, actually people are reporting that they're not travelling to see friends and family as much. So about half of people have already made the change and conscious decision not to travel to see friends and family. And people are reducing the amount of social activity that they're actually taking part in. The majority of individuals, like most of us, are reducing the amount of time that we have our heating on, wearing more clothes to stay warm. 15% of the people that took part in the survey said that they've used the warm hubs, with an additional 20% considering using that in the future. When it comes to food, that reduce the amount of food they buy and eat, with 36% reporting that they're buying less healthy food, 12% using food banks. When we look at the comments around the survey in particular, things are coming through around people with diabetes not being able to manage their conditions because they can't buy or shop around for cheap enough food to manage and eat healthily. So, and 62% of individuals are avoiding using essential appliances to save energy costs as well within their home. The bit that I've pulled out here is, again, around 2/3 of people are reporting that the changes that they've made are causing them increased anxiety and negative impact on their mental health. And that 68% compares to 39% nationally reporting that. So there is something there around locally, the impact around mental health and increased anxiety that's coming out. In terms of access to health and social care, so it is coming through that people are avoiding health appointments due to increased costs. So that's around phone costs or internet costs, travel expenses, or taking time off work where they won't be paid if they attend medical appointments. So roughly that's around 10% to 15% of people telling us that. That weighs up to the national figures on these areas as well. So around 10% of the population are avoiding those medical appointments due to cost of living. And that goes up to 34% of people avoiding dental care treatment because of the costs as well at the moment, if they're able to get appointments. A number of people are reporting that they're cutting down on the medication, over-the-counter medication that they use, that they normally rely on. And that they're making conscious decisions to cut down on the number of items they have on prescription as well that they rely on. Again, that's around 10% of respondents, which marries up to the national. And 12% of people have reported to us that they're stopping special diets that they need for a certain condition, which is having an impact on their health. In particular, in the comments, people are reporting to us that the main areas that they're reporting to us is around reducing being cold and the effect on pain, arthritis, conditions like that, where actually living in cold conditions is making that worse. That's having an impact on their mobility. That's having an impact on them getting the help and support they need and within this time. Just some consideration around next. This is a live survey, so it's still out there. We will continue this, I think, until we see a pattern emerging within the data or anything changing or improving for the local populations. The main thing is that we want to report on this on a regular basis so that anything that comes out of our survey can be acted on to help and support people. So linking up with the cost of living partnership group would be useful around this presentation following this. We are going to be slicing the data a little bit more to understand if there's any inequalities within our city, either communities of identity or geography around that, to see whether there's any pockets that come from that. Nationally, Health Watch England are reporting that there's a disproportionate effect on women that's coming through in the national data on this. So we'll continue the survey for as long as we need to. And link into key groups. So there's just a few questions really that I'll proposed here. Just is this useful? Do you want just to come back? Where else can we feed this in that would be useful? Are there any other questions that you'd like us to think about asking or building on that? And are there any, from what's been reported today, are there any key areas of work that have already actioned to address some of those issues, or is there anything that can happen as a result? I'll stop sharing there.
Thank you, Andy, for going through that really helpful and useful detailed information and presentation. I'm going to just check to see whether people have got questions or comments, but before I bring anyone else in, I've just got a quick couple of questions of my own. Well, actually, I'll answer the first question that you asked, whether or not I think this is useful. I do think it's very useful information and quite helpful to be able to put things into perspective. So yes, please, if that data is being collated, then we are interested to continue to have updates and hear it. And one question I had in relation to the data is whether or not so far this is being fed into the council's corporate cost of living work that's being done.
It hasn't as yet, so that's one thing that I'd like to report. And that's some conversation there. We have reported to the ICB's quality group, and we also reported to the adult social care managers group. But actually getting that wider partnership would be useful.
Yeah, okay, I think definitely as an action point from this, we can tie that information together and make sure that this is fed in as well. And then and at least our response can then match the information that you're being able to pull out. The other question I had was just how often is the data analysed or monitored or pulled out? I know you've sort of pulled together the most up-to-date data last night, but it's just as it's a live moving kind of document or piece of work, it's just in terms of how regularly are Health Watch looking? Is it weekly? Is it sort of?
We're keeping an eye on the data quite regularly. So part of this is an opportunity to identify where people need help and support as well. So we're regularly going in every couple of days into the data to pull out people that we can contact to give information and signposting. So it's a live survey. It can be collated really quickly. So if it's useful on a monthly basis, or at least every health and wellbeing board, we can do that.
Okay, thank you. I had Justin and then Richard.
Yeah, so I'll make connection, Andy, between you and Greg, and we could have picked up through the partnership. Well, because one of the things the City Observatory is very keen to do is enable voluntary and community organisations to be able to feed their data in. And there's a significant amount of work, and Greg may want to pop in on this point, that the Observatory's done mapping, for example, of call centres geographically, where the call's coming from as well. And that's informed the food work around where do we prioritise food bank investment, etc. So it's a useful piece to add into the jigsaw of data around this. But Chair, if I can ask Greg to jump in on this point, he may want to add some more on that.
No, just sorry, Chair. Would that be okay? So yes, I mean it would be very very good for us to meet to talk about it. We can arrange for City Observatory colleagues to be there as well. There's definitely a need to share more data, and it. I guess our joint ambition will be to try to as tightly as possible target those people who are most vulnerable in this area.
Thank you, Greg. Richard.
I'm Darren Fraser, I'm Richard's deputy.
Sorry.
Yeah, no, it's fine. That's it, fine. Thanks for the presentation, it's really helpful. I'd like to invite you to stand on West Birmingham to present the trust, because I think the data is really important. And the question I got was about the kind of reduction in frequency of prescriptions, the reduction in management of people's wider kind of ongoing health needs and all that sort of stuff, and whether or not we got an opportunity to link that together with the care that's being provided, because I think we will, through our normal surveillance, miss these individuals that don't turn up for the appointments because of the backlogs we've got post-COVID. So I think there is a piece of work that we probably need to do with the data you've got, maybe with the public health teams and the wider NHS team, to have a look at the
whether or not there's a bigger impact here than the first layer of data issue.
Thank you. Claire, shall I bring you in next?
Thank you. I mean, Darren, mine's a little bit of an extension of that, really. Is there two aspects? Is one, I wondered whether the healthcare providers who charge for parking are actually making sure that people are aware of those who are able to claim expenses within the hospitals when they come in, because it's not, the cashier's offices are sometimes not the easiest places to claim expenses from. So I just wonder whether there's a good publication around that, and also whether there's a piece of work for us to do around accepting that a lot of people get free prescriptions, but also accepting that those who may be in most trouble are those who just don't get free prescriptions, whether there's something around how often repeat prescriptions are issued, in that sometimes there doesn't seem to be sometimes people are having to go back every month, or sometimes every 2 months, or every 3 months, and there seems to be little standardisation. And of course, if you have to pay a prescription fee every time you go, I do wonder if there's something that we should be looking at in that context around the dispensing fee.
Thank you. Justin.
Yeah, I know Stephen's waiting to come in, but I just want to pick up particularly Clara's point. I think it will be also really sensible, given the national discussion around menopause, particularly to look at this in terms of prescriptions that are repeated, like HRT, like the contraceptive pill, as part of our commitment to inequalities. And I think that would be a really powerful statement around actually thinking around people that it's not an intermittent charge, it's something they have for a large proportion of their life, and women are disproportionately affected, I think, by prescription charges in this space.
Thank you. Stephen.
There's a couple of things around data situation agreements. The first one, patient exclusions from healthcare provision. So I know we've had conversations about this. There's certain reports from contraceptive organisations. Certainly dentistry moving over to essentially the big NHS places, and then people are so that's certainly significant change. If it's possible, capturing whether we're doing well around connectedness of our services and people going out and food bank. Again, First thing I think was that the data that seems to be significantly in of the national averages. I think given how exposed we were as a city with over lots of information, I wonder whether I know that as a city we tended to focus on policy right across the field, but there doesn't a particularly strong long-term strategy with metrics, and whether as a board,
Thank you, Stephen. Did you want to come in?
Yeah, I mean, I think that's the piece of work that Richard's shared at the partnership board earlier this week, is looking at what is the citywide partnership response to poverty, and whether that culminates in a poverty strategy or something else. But what we have demonstrated is Team Birmingham responds incredibly well in a crisis. We've done really well kind of in the firefighting phase. The reality is this is a fire that's going to continue to burn and continue to flare up at various points through the year and probably for several years to come. And that requires quite a different strategic approach that gets into conversations around job creation, around affordability, around the economic environment, the city. So Richard has committed that that's piece of work he's leading on. I think there's a question offline, Chair, about whether that sits with the Health and Wellbeing Board to oversee or a different bit of cabinet, but it is something we need to bottom out as the governance of that piece.
Thank you. I think based on the comments and the questions that you've raised, we'll keep an eye on how that piece of work develops and see where it seems most appropriate to have that oversight. But either way, even if it means that it doesn't end up solely as a piece of work for the Health and Wellbeing Board, that we're still connected into it and able to feed into it and ensure that partners around the table here are directly involved in that citywide corporate piece of work. I've got Councillor McCarthy, but I wondered if I can bring you back in, Andy, at the end, because I know that there's lots of things that have come in, so you might want to sort of respond back together. But Councillor McCarthy.
Just on dentistry and prescriptions, we've all had the horror stories about people attempting DIY dentistry, but I wonder if we've got any data about increases in people accessing the dental hospital or other emergency services that would indicate that they're not able to afford even NHS charges. And the other issue around prescriptions, I saw something on television where they covered the length of time that prescriptions are covering. I realise that somebody who is having to make that decision between food, heat and prescriptions may not be able to afford a prepayment certificate, but it is worth mentioning it when we've had these discussions. And they also talked about is it the minor ailments scheme for people who do get free prescriptions, and I think we should make sure.
Thank you. Clara, did you want to come back on the first? Dentistry.
So we know that quite a lot of dental work presents through the urgent treatment centres across the patch, and there's without doubt an obvious need around dentistry. We are about to inherit dentistry from NHS England from the beginning of April, and I think there's a dental needs assessment that we're doing in collaboration with the Black Country as well, to begin to outline where there are particular issues around that. So means that the commissioning will be closer to us as a delegated function to the ICB. Whether that means that we'll be immediately be able to change it, because of course so much of it is run by practices for individuals, whether they do NHS or not, but at least it'll be closer to us to be able to investigate further.
Thank you. Natalie, do you want to come in? Okay.
I'm not sure whether you've seen it, but there was a communication yesterday on Tracy Harvey, a list of lending practices who are able to provide a full range of dental services for refugees, migrants, and experienced homelessness. If the board hasn't had that, I believe that's right.
So if you can send that to us, and we can make sure it's sent out to everybody else. Thank you. And then Andy, I'll bring you back in. I know you've got lots of
just a few of the points.
Yeah.
And I've presented to the adult social care group, the observatory, and making sure that our regular feedback around health and social care gets fed into that. And I'll step up the work on that though, so this cost of living stuff can feed in a quicker basis. So yeah, that would be really useful. I think Stephen, working with yourself to identify how we could develop this a little bit further, working with food banks and our community engagement workers could always go and speak to people at the sites that might be useful to increase that. They are doing some work going to the warm hubs to speak directly for people, so to build some of that in. And then I think the other bit, there seems to be a bit of comms needed here around awareness of when people can claim back travel expenses, visiting the hospital, stuff around awareness of prescriptions and actually signing up to things and what's available to people. So maybe we could do a piece of work looking at that comms and making sure that that gets out there moving forward.
Thank you so much for bringing this presentation to us. I'm just checking the time now because so the next item on the agenda is item 12, which is the Better Care Fund addendum plan, but Mike Walsh will be joining us just after 11 o'clock. So for that reason, I'm now going to skip not to item 13, which sounds like it would make sense, but instead to item 14, because I know that there's other people who may have to leave fairly soon, but might want to hear this presentation. So I'd like to bring in Dr. Justin Varney to present this item on the Perinatal and Infant Mortality Task Force update. But before Justin does this, I just want to bring to members' attention that there has been an additional paragraph inserted into section 4.4.10 which starts off with linking to the children and young people's plan. And then I'm not going to read through that, but you will be able to find that given the reference. So I'll hand over to Justin to present this item.
Great, thank you, Chair. And Marion Gibbon sends her apologies due to other commitments. She wasn't able to join us today, but Joan Bradley from the team who's led much of this work is with us as well. The paper sets out the update of progress on the infant mortality task force. And I'm really delighted to see actually much of what we talked about as kind of vision for action is now really starting to move, and we're starting to see things being piloted, fundamental shifts happening in terms of practice and care. The recommendations have been taken forward, and there's a report to HOSC which is appended to the report, which goes through those recommendations in detail. But the key achievements, I think, are for the board to acknowledge that the working groups have been established and the work streams are moving forward with chairs. So the research work stream chaired by Joe Garstang, and some of the research that we've done on genetic screening proved to be incredibly timely as NHS England changed some of its positioning around genetic screening. So we were slightly ahead of the curve in that space. The work on co-production, and I would encourage colleagues to read the annex, which is the Seldom Heard Voices report. It's a really powerful testimony from women who've experienced infant mortality and their experiences of our maternity services. And I know that Clara and Lisa and colleagues in the ICS are actively taking forward reflection on that feedback, and there are some pilots mentioned through the report as well, which reflect the progressive work being taken to move forward on cultural competency in our maternity services. We're working closely with Lisa Stadler-Green, who's taken on chair the local maternity and neonatal system, to appoint a chair for the implementation board. And I think, looking at Joe, that has now been agreed, a clinician to lead that, as there's been some restructuring of the LMS. The final thing I'd highlight from this paper, and there's a lot of information in the report, is that, like many other areas in the West Midlands, we did see an increase in infant mortality during the pandemic. Sadly, unfortunately, that wasn't unexpected, but I think it is important for the board to acknowledge that and be aware. We're still waiting for the final set of national statistics, but there was an increase. And this was particularly in the very early stage of infant mortality, the early deaths. And we're working through the Child Death Overview panel with the LMS to look at the individual cases and identify any lessons that can be learned moving forward in terms of addressing it. But I did want to highlight particularly to the board, because it will mean on our trajectory to improving infant mortality, we have gone up rather than down, which is not what we were hoping for. But as I said, was expected during the pandemic, as there were significant challenges in women receiving maternal care and support during the perinatal period. But I'm happy to take any questions from the board on the report. As I said, there's a large amount of information gone with a total transparency approach for the board. We feel this is something the board had felt very strongly about, and therefore included a series of reports for the HOSC report, the full data pack. And as I said, I would really commend the Seldom Heard Voices report to you, because I think it really brings to life what we're talking about.
I'm going to make a suggestion before I bring anybody in, just in relation to continuing getting an update on some of the work around not just infant mortality, but just the wider bit of work around maternal health across the city. So I want to suggest that the local maternity and neonatal system, if at a future meeting, perhaps at the March meeting of the Health and Wellbeing Board, are able to provide an update, including any actions that they are currently taking and the work across the system more widely, if that can be sort of agreed and requested. Is that okay? Thank you. Thank you, Clara. And I'm now going to bring in Councillor McCarthy, and then I'll bring in Andy.
Thank you, Chair. Seldom Heard Voices work is so important, and listening and responding, particularly to our city's young mothers, is key. We need innovation and inclusion in our approaches to tackling this issue. Preventable loss of life of a baby is one of the most devastating consequences any family could ever face. And some of these deaths are preventable through a range of earlier actions and awareness and earlier conversations prior to conception and during. In Children's Services, we're working on our 5-year child people's plan to 2028. And we've held a workshop and are working on infant mortality, preventable deaths and early intervention, because it's crucial to consider to support children, young people and families toward healthy relationships, pregnancy and children. Our pathways from hospital, maternity services, public health, nursing, to support infant health at home and in the community in the first weeks and months.
Thank you, Councillor McCarthy. I'd agree with everything that you've said, and I'm pleased that you were able to give a bit more reference into the additional bit that I mentioned earlier around the linking in with the Children and Young People's Plan. And just in case anyone didn't catch that, the inserted section is 4.4.10, and I'm really hoping that that's accurate because I haven't double checked it, but I have faith that it is that. Can I bring in Andy next?
Yeah, thank you for this. We did initially connect with Mary, and we need to judge that back up just from the just like analysing the report, working concern of West Birmingham Hospital Trust, findings of that, but going to connect with the ICB, and I think really felt just it would be great to link that work in.
Is around cultural awareness and those underlying health conditions for the population are really important to highlight.
If I just comment on that one, yes, I mean, I'd say we're fully aware of the research and it links both to the infant mortality work, but also to the Black Ear work that we're leading on cultural competency and cultural safety, humility. So it is well connected, and we look forward to seeing the report because I think it'll be really useful to all.
Thank you. Yep, and
yeah, I can comment on all this here. I'm really insightful. Yeah, so I just wondered about homeschooling. That's the recent report by Shelter in 21 popped off, and women from Birmingham did that report was a significant growth, having previously worked as a dietitian in that area. And they're the biggest receiver of temporary accommodation as well.
thank you, Anne. Justin, did you want to?
So I may need Joe to jump on the front table bit to respond in terms of
of course.
This, but Clara may also want to, and Doug may have a comment actually in terms of the provider.
Yeah, I'll bring Joe.
I think, definitely around the temporary accommodation, we're picking that up significantly. A piece of work's just been completed by Birmingham Community Healthcare Trust around temporary accommodation, venues, who lives in them, what support they might need and access, and we're picking up lots of different issues specific around a whole host of things that can impact around infant mortality. So yeah, it's definitely something that we're aware of and are looking at what actions we can take on that. That'd be great. Thank you.
Thank you. Clara, would you like to come in first, and then I'll bring Doug in?
One of the things that I was just going to mention is that the seldom heard is great, and there's lots of really rich feedback there. One of the things that worries me slightly is how exactly we are ensuring that all of this rich qualitative data, whether this be Blackshire or these elements, are landing back with our healthcare professionals and then changing practice. Now, it may well be being fed in through midwifery and things, but I am unsure as to how it is being progressed through our medical professions and then within our trainees across this area. And it may be something that we just need to ask, because there's so much rich data coming back, and unless it is presented back to the staff who are caring for patients in a way that they are able to process and take on as something that's important to hear, we're letting down the people who've given us this back. So I wonder if that's something we may want to pick up somewhere.
Thank you, Clara. Doug, I'm so sorry. I'll bring you in just after Justin's able to respond to this point. Thank you.
Yeah, and I think what I'd suggest is we put on a forward plan an update specifically from the Black Ear programme on what we're doing around cultural competency, because the way that Black Ear is approaching this is one element is cultural intelligence, which is particularly how do we take these reports, embed them into training and understanding, both at a strategic level and as a training level. And then the separate parallel piece is around cultural safety and humility, which is around the personal interaction with patients. And things like Seldom Heard feed into both strands of work. And I think it'd be useful to bring back to the board as separate to the kind of Black Ear updates, specific presentation about how we're taking forward through that programme, exactly that kind of question and answer.
Thank you. Doug and then Stephen.
The BCHC work, there are 4,000 families who are on homeless accommodation in the city. There are 3 health visitors who are specifically an active user and antenatal visit. I'm slightly, what I want to talk about was a couple of things. One was the slide 1318, which is the long view and infant mortality, 30 years, and because it's a really difficult issue to address, but that does show quite a significant reduction in Birmingham, better than in the rest of us in terms of trajectory. It's still higher, but I guess the stat that upticks isn't adjusted. That goes up to 7.6. I guess the question I was interested in is, what do you think, maybe both of you, is the biggest bang for our buck? What are the biggest interventions we can do in a really complicated, multifaceted issue? Where do you think we should invest in the energy?
I think there's modifiable factors. I think that's been an ongoing discussion within the task force, is that how we can the opportunity to impact on the price. That and then smoking,
all of those sorts of things I think are vital in the work that we do. So yeah, that would be my first go-to.
I think from my perspective, and I probably would say this as Director of Public Health, the big thing that will change this for the future is fundamentally improving the life opportunities of women in Birmingham, and that's their housing, that's their employment, that's their education. If we're looking 10 years out, the modifiable factors are very individualised, and we continue to work in that space. But to really shift Birmingham from being always bottom of the pile when it comes to infant mortality to being much more in line with some of our other statistical neighbours, we've got to have concerted effort, I think, around the support for women to achieve their potential, because we know that will impact overall on the opportunities for their children.
Thank you. Stephen.
Thank you for the breadth of the information. I might have missed this if it's in the document there. Have we returned after the pre-pandemic position? It's a little bit when you define the pandemic situation, but just trying to understand where we are now.
If I may respond, so we won't know that for about another 18 months, whether we return to pre-pandemic, because in effect, we have to wait for all of the children that are born and then die in a year to die before we get the data. And then there's a time lag between when we get that from the Office for National Statistics. So infant mortality data generally runs about a year behind where we are today. That being said, we are monitoring through the Child Death Overview panel, which gets real-time information when children die. It triggers a process to look at that information. That gives us a indicator of whether we're heading in the right direction or not. And at the moment, again, we're slightly too early in the time frame to be able to go, we're back to pre-pandemic, it's restabilised. My suspicion, given the earlier discussion today and the cost of living pressure and how much that links to some of the risk factors for mortality, like overcrowded housing, poor nutrition, smoking, maternal mental health, I suspect that any recovery from COVID will be minimal while we continue to battle the cost of living. So I don't expect there to be a kind of bounce back at this stage. I think it will take longer. But we won't know. Probably the earliest will be the autumn when CDOC's got its data from 2022 completed.
Given that the expectation is that not going to go in the direction of sufficient hygiene.
I would say, I think there are, and I think the value we have of having an independent chair, and Shushma Aquila has brought a level of chasing to action, which we may not have achieved had we retained the chair through officers because of the other pressures we have on time. So one of the reasons we brought in an independent chair was that she has been extremely persistent, particularly working with colleagues in the ICS as the LMS has gone through some significant changes to keep an eye on the ball on. There are clear things that need to be changed. When are they changing? Why haven't they changed yet? And moving that forward. I also think as the ICS have formed, with Lisa as chief nurse and deputy chief exec taking the leadership for this space, reflects the commitment to the ICS to really drive through some of the fundamental things that need to be improved across the system. And it's particularly helpful also bringing Samuel and West Birmingham now into that discussion where previously they'd sat in a different LMS, which hasn't helped us. So I think we're in a much stronger position, but we will continue to report to the board on progress, and it's important the board continues to hold us to account if you feel that this is not delivering at a pace you would like.
Thank you. Okay, so does anyone else have any questions or comments on this item?
Just to point out that in terms of, if you analyse in terms of years of life lost, which is one of the analysis, this is by far.
Yeah.
Because they die so young.
Yeah. Okay. Thank you for presenting this item and for the discussion around this. I know that Mike is now in attendance, so I'm happy to move back to item 12 for Mike to be able to present the Better Care Fund addendum plan for,
Respect approval for a addendum to the care plan, respect the other social care discharge fund. So, a bit of context first of all. Government announced in September last year an additional 100 million fund to support discharge from acute care to social care over this period. One of the requirements of receiving the funding was to plan on the 16th of December. Funds came out in November, so in terms of the approval process before that, there wasn't an opportunity to bring it here in advance. Councillor Khan is the chair of the board. So the funding that's been made available to us is just under £9 million. It's been allocated in quite a complicated way to both the City Council and the ICB, and in two tranches. One paid on as sees the plan, and the second tranche was paid just yesterday, I believe. So all of the funding has been received by us now. The plan's attached as an appendix. The focus of the plan, as the name suggests, is very much around directly supporting activity that enables discharged people from acute care when they
no longer have a reason to stay. So it's typically people who aren't able to return home, but have an ongoing care need. Guidance is also particularly focused on actions to support discharge around acute mental health as well. As mentioned, the plan's attached as Appendix A. The key intervention that we've out of the plan and allocated just over £6 million to is around supporting recruitment and retention in the independent care sector. So we've viewed this really as the biggest risk in terms of achieving discharge out of acute care, and the most effective way of deploying this resource at scale in the time period to the end of March. We were able to last year and found it very effective in terms of generating additional care hours and retaining staff and discharge. So on that basis, we mentioned this year as well. However, we mentioned the plan, additional home care, support for potentially to PCC care staff, good type of social care, which is for bespoke for those with complex care needs, and that focus around mental health as well, including a new mental health home, hospital home pathway, much needed. Implementations now remains the schedule reporting to NHC next reports due tomorrow, and we spend around about £600. Obviously, the area of spend is that payment to the independent care sector. In order to release that payment, we need to get cabinet approval, and we're on track to get cabinet approval. Next cabinet meeting in February, and we can then move to make those payments into the independent care sector. So I'll pause there for any questions. Thank you, Chair.
Thank you, Mike. I just check to see if anyone's got any questions for Mike on this item. No? Okay, in that case then, just for me to be completely clear, if there's no other questions, I can just check if members of the Health and Wellbeing Board are happy to approve that this can proceed to the next step in order to get onto Cabinet for the February meeting. Is that what you need from us, Mike?
It's just approval of the plan.
Okay, I'll just check to see whether we've got approval. Agreed. Thank you. The next item that we've got is item 13, which is a 000 drug and alcohol strategy, and Dr. Mary Oroware is online and should be presenting this item. And Chris is joining us around the table.
Yeah, good morning, and thank you, Chair. So can I just check that you can hear me?
Yeah.
Great. Okay, so this is about a journey that we've been on with regards to our substance use agenda across the city. It's the process that is the document set before you capture the work that's been done and the process over a number of years. This started before the pandemic, and some of it was paused, but we got going again pretty quickly. And we've done a number of pieces of work in terms of finding out what we had, what was needed, and how we go forward, looking at this as a system. At this stage, I will let Chris, who is in the room with you, take you through the actual pieces of work that have been done to get this far, and then I'm happy to chip in afterwards.
Thank you, Chris.
Thank you, Mary, and thank you, Chair. So as Mary's explained, the pack of papers that are titled 000, and I'll come on to that shortly, are the end of a long journey for us. As we were unknowingly heading into the COVID-19 pandemic, there wasn't a single document that set out how we as a system wanted to work together as a system and what we wanted to achieve around the substance use agenda. The local authority public health team are responsible for commissioning drug and alcohol support services, which is what we've been doing since the transfer of public health into the local authority in 2013. But there wasn't a system-wide strategy. So that's what we set out to achieve. We consulted, slightly changed plans, obviously, because of what happened, but we did consult on a draft strategy. And we had a lot of feedback over, around 900 responses, just under 900 through the BHERD site that we used, and we had some additional responses by email. We sought to make sure that the engagement around the consultation was as wide as possible. We engaged with interested professionals and organisations with a role in the substance use agenda locally. We worked with our service providers to make sure that service users had a voice and a way of contributing on the consultation. And of course, we put it out to public consultation to allow everyone who was interested to feedback what their thoughts on the draft as it was at that stage were. We see the 000 strategy as an opportunity to bring all parts of the system together, like I said, in a way that wasn't done before. On the whole, and I should explain, you've got the analysis of the consultation feedback in your paperwork, so I don't plan on going through that or the other papers in great detail. On the whole, there was wide support for setting up a system-wide city strategy for drugs and alcohol, but there was some pushback on some of the terminology, some of the language we'd used, not just the language and how it wasn't easily understandable, but also questioning some of the terms we used. So you'll see in the analysis and then in the usage, we did document that we've attached how we've taken those comments on board and what changes we've made as a result. So the strategy you see now is a result of all of that feedback, and also as a result of the additional analysis we've done and the production of the needs assessment, which you have in your packs as well. There's a full needs assessment, which is a very long document, because of the breadth and depth of the data that's available to us. There is an executive summary, which is a shorter version of the needs assessment with the key points for your information. Say that the strategy that you have in front of you is both a public and a professionally defined strategy as it stands now. It's those of you who might have seen the original draft back in 2020 at the Health and Wellbeing Board, it looks like a very different document and it reads like a very different document. What we're seeking to do is to ask the Health and Wellbeing Board for its approval to progress onto Cabinet in a few weeks' time for their consideration and hopefully approval to publish the pack of documents. We'd also like to just ask for approval for our proposed governance as well. So within the current policy framework around the drug and alcohol agenda, there's an equal focus on treatment and recovery,
and on community safety and enforcement. And these don't neatly fit in one governance or reporting or accountability route. So what we're proposing is that the recovery and treatment elements and all the additional indicators that go around that and the activity that we will develop over the coming weeks, we would like to propose that we're accountable as a system to the Health and Wellbeing Board for those elements, and also as a system accountable to the Community Safety Partnership for the community safety and the enforcement elements. So we'd like approval for that as well. And I should add that we now have a West Midlands Combating Drugs and Alcohol Partnership, which is led by the Police and Crime Commissioner. So as you will see, the governance diagram towards the end of the strategy explains how our proposed governance within Birmingham fits into the wider regional governance arrangements. I think I'll leave it there. Like I said, there's a lot more detail in your packs. Mary and I are happy to take any questions.
Thank you, Chris. Can I just see whether members would like to ask any questions? Councillor McCarthy.
Just a brief comment to highlight the work for young people within this. Services delivered by Aquarius covers both young people, other substances, and those affected within their families, which we know can be a lifelong effect in itself, and the partnership working around young people with particularly on homelessness and substance abuse, mental health, on child sexual exploitation, strong links into the youth offending teams, whether or not there's a direct link between the behaviours. So whether these other issues have contributed to the alcohol and drugs problems or are the result of them, this strong is there to provide the support that I.
Yes, thank you very much, Councillor. Yes, for those who aren't aware, we commission children and young people substance use service, as Councillor McCarthy has just described. Through Aquarius, we commission an adults treatment and support service through Change Grow Live.
And just a point of clarity, I think, in terms of the governance, and Mary will correct me if I'm wrong, but I think given both the significant amount of additional funding that we've received from the government in short time frame, but also this is an area in which I think as a city we will continue to be challenged, not just with existing drug and alcohol use, but also new products. Many of us are very aware of the current discussion nationally around nitrous oxide and its potential harms, which we hope will see change and reform. That the established new group would report directly to the Health and Wellbeing Board as a formal subgroup, certainly for the first 2 years. Or, and Mary, correct me, is it 2 or 3 years we have the additional funding for? It just strikes me that since there's such a large volume of additional resource, it would be sensible for this group to directly report to the Health and Wellbeing Board.
It is 3 years, the first of which is nearly up.
So are you comfortable with the suggestion then, and the board comfortable that this is a direct report?
Yeah, I am, and I'm getting nods around the room as well. Okay, I'll bring in Clara and then Matt.
Thank you. I mean, I didn't see the original strategy, but obviously this is a nicely presented document, and you've taken on board the feedback that you've had. Just a few comments from me, though. I mean, I personally don't think recovery is emphasised as much as treatment and support within this, and I do think that is that's something that needs to be brought through a little bit, perhaps more around the implementation. The thing for me is, and again, is that so what of the strategy is what are the next steps associated with this. And I think that we do have an opportunity to make sure that my job as Chief Medical Officer of the Integrated Care Board is to make sure we are joining properly across services. I mean, this is obviously commissioned through the local authority, but the link around dual diagnosis and mental health is absolutely key. And I see Regulation 28s come out quite regularly from the coroner around the lack of joining up of services within this space. And so I think that particularly with the formation of the Mental Health Provider Collaborative now through the integrated care system, that it is really important that we join up through that mechanism. And I think that we therefore need to make sure that the Combating Drug and Alcohol Partnership is the membership of that is really looked at carefully to make sure that we are using this opportunity to join up across the system as much as possible, equally into primary care and into our secondary care institutions, to make sure that everybody is joined up and knows what services are available and is able to signpost and indeed takes this on as something that feels to be important. I think it also joins across to bloodborne virus testing as well. That again is something else that is coming across in other areas. And then just finally, there's an awful lot of numbers in the accompanying documents, which are great. But although we're aiming for zero, the 000, which of course I support, I don't have a feel as what good looks like in association with those numbers. So there's, for instance, a reduction that there's fewer people in treatment for alcohol, for instance. I don't know whether that's good or bad, or I'm assuming it's not great given that the unmet need again comes across to that. So there's a narrative in there around the numbers, but I don't have a feel for what good looks like and what we should be aiming for, accepting the ambition of zero, but what we should be aiming for in the meantime. So I think all of this is just picking up in that implementation of the strategy, but I think we have an opportunity here to make sure that we are more explicit and join it across.
Thank you. I think before I bring Matt in, on the last point, certainly, I see completely where you're coming from. And as much as zero being an ambition and ensuring that we won't sort of accept anything else as an ambition and a vision, then in terms of being able to monitor progress on an implementation phase certainly needs to be looked at, because otherwise, any kind of reduction without being able to have that bar to compare it to can always just seem like, well, we're on the journey there. There is some improvement, but without knowing at what pace it needs to be delivered at. So I agree that there is some thought that needs to be done around the next stage of implementation, and maybe being able to reference that, the extra bit of work within the actual strategy. So I'll bring in Matt next, and then Natalie, and then Stephen.
Thank you, Chair. 2 points if possible. The first is that I certainly commend the proposal around governance. That delineation for me is something that has been long overdue, and something that I think in the past the city hasn't necessarily been very good at doing at a strategic level, and sometimes has led to duplication of governance and accountability. So I think having that delineation is very welcome. The second point picks up a little bit on the recovery piece, and certainly Chris knows because we've had discussion on this. So one of my concerns from my perspective in terms of my organisation is that quite often the treatments are aimed at bulk of the distribution curve, but when you look at the harm and risk, it typically sits at those the minority that disproportionately are causing the issues, both in terms of policing and in terms of community and society. And it's whether it's felt that the strategy is sufficiently takes account of that, because otherwise we end up with a situation where they are the forgotten ones that continue to be the ones causing the greatest issues.
Okay, thank you for that feedback. Natalie, and then Stephen, and then bring Chris or Mary back in.
Yeah, I just want to say I agree with everything that Cara said, and actually my just articulated the point very clearly that I was also going to make around those that are most marginalised. And I think that this strategy in the city for a very long time, and it's great to see it hit there. Things in there. I think what I wanted to reflect on was really in terms of those measures and the governance is the key risk for me is those high figures of those that aren't currently within services or receiving treatment within the city lies, and I think that's how what Matt's saying about those who are most marginalised. Within the strategy, it talks about some of the work that's been done again around specialist teams, and I know that the work specifically around the homeless team has worked really, really well. That was very much from a memory of very reactive piece of work in relation to sort of pressures post-commissioning, because that hadn't been considered at the point of commissioning services. And I think if we're really serious about translating this strategy into action, we've really got to be hot on thinking about, well, who are those that aren't in treatment? What do those groups look like? And how do we go about creating the specialist resources and services that are going to make access and engagement a reality for those people, putting the ownership on us to do that, and not with them to engage in existing hubs or actually just about how we design that service to fit now when to engage with it.
Thank you. Stephen, did you want to come in?
The vision, I think, of such a brain is very laudable. There was something about the way that the document was constructed that seemed like slightly a relic of how we used to do things in Birmingham. It seemed very much it seemed quite transactional in its presentation, and the focus on the social context that we're functioning in, the fact that there is a community of interest there around people with addiction issues, that we have assets in the city that support people maintaining their recovery rather than just two blocks of service provisions. All of that there seemed to be a different focus on it than we would get in other areas of provision in the city. And I appreciate the shift in focus away from criminality towards it being a health issue, but it seemed like there's still a bit of work to be done about shifting this to bring it in line with the rest of the provision in the city.
Yeah, I mean, I think it's interesting. So, I mean, I think the strategy does highlight quite well marginalised communities and and keep in mind the strategy is the vision, it's not the delivery document, so there's a lot more detail to come, I think, through the implementation. I think one of the other things is to keep in mind this strategy is an underpinning strategy to the Health and Wellbeing Board strategy. That's where we got the kind of headlines around all of these things are driven by economics, around housing, around education. And while I acknowledge that, in not every strategy we've always got that front and centre in the way that, because it's varied between different strategies about kind of how much we can do at a local level versus how much we can do at a national. The other thing I think is quite important in the context of this strategy, which is slightly different from the food strategy that feels quite different, is that in the drugs and alcohol world, this is a bit of our kind of homework that gets marked. It is part of something that is nationally scrutinised by the Home Office, by some of our funders. So it is written in a particular way which has to think about that. And that's why I think it's important to acknowledge it is slightly different from, say, the food strategy, where we're in completely kind of blue water and we are very much getting to do what we want. In this one, there are certain things we've had to stick to the national rule book and the way we frame it. I do think that the team have done a really great job in engaging and working with systems and with partners in developing it. And one of the reasons it's taken quite a long time to bring back to the board is because we wanted the needs assessment to sit alongside it. And both the strategy and the needs assessment then will sit underpinning our next commissioning cycle. And while I think certainly none of the public health team were around when this was originally contracted, I know it's a service, in terms of the service provision side, is something that's had a bit of a rocky past. So I think it gives us a good set of ambitions to build on. But I think it is also a point, Stephen, would pick up outside about how we clarify that connection up to the overarching strategy, both of the Health and Wellbeing Board and of the city, and where the wider drivers and that really upstream prevention space sits, because it's not just what we do will impact on drug and alcohol, it will impact on poverty, it will impact on all sorts of things. And we haven't quite got that narrative right, I think, yet, and we need to think about how to do that.
Thank you. Just wondering whether Chris or Mary want to come back on any of the points that have been raised. Should I bring Chris in first and then Mary, you can come next?
Thank you, Chair. So if I try and take all of those comments in order. Thank you, Clara. I would agree with you. A lot of the points that you raised are, in a way, the work we've done so far is it's not the easy bit, but it's the implementation which is going to make the real difference, and the action plan and the work programme that follows. So I absolutely agree. Recovery is a key part of that action plan, and also part of our re-procurement phase that we're heading into as well. So that will be in there. Dual diagnosis, absolutely. We talk about interdependencies and complexity that members of the community have, which impacts on their substance use in the strategy and in the needs assessment. And we're having a lot of discussions around dual diagnosis. I've had some meetings with some of your colleagues from the ICB on that as well. So there's a lot of work still to do. And that will be a key part of the implementation plan. And yes, there's links to the BBV testing, and I also sit in some of those fast track cities meetings where that's coming up every time. So I'm very aware of that, and we're looking at that. I take your point. What does good look like? Because whilst we're clear, that was one of the pieces of feedback we had on the original draft of the strategy, that people felt the targets as they were written at the time were unrealistic. And we've clearly reworded it. We haven't changed the ambitions, but we've made it clearer that they are ambitions and that the population deserves no less than those. So I think there is some work for us to do on explaining the narrative around what good looks like. That's very helpful, and we'll take that forward. Thank you. And I think that will feed, Chair, into the comment you made about how important monitoring progress will be. So there is a lot of, within the context of the National Drug and Alcohol Strategy and Plan, there's a lot of additional funding flowing into the city, into the public health team, from the Office of Health Improvement and Disparities and other government departments. And we are accountable under outcomes frameworks for that delivery. As Justin said, there are clear requirements that we need to deliver within that. So I think translating that into a local outcomes framework as part of our implementation and monitoring will be important for us. Yeah, as Matt said, the governance and the delineation is really welcome. It took some time to get that right, and we worked hard on that. And that has gone through the Community Safety Partnership and been improved there as well, just to be clear on that. And I think understanding within our outcomes framework around the difference between the majority of service users and those who maybe have more complexity and contributing more to impacts on society and their families and their local communities. I think that will be important for us to get right. Absolutely, Natalie, you're right. The problem and the risk is those not in treatment. I also sit on a group that reviews drug and alcohol related deaths, and approximately half of our drug related deaths are not in structured treatment programs. So within the ambition to get down to 0 overdoses and 0 deaths, reaching those not in structured treatment is going to be a big ask, but it is something that we're really focused on. And Stephen, I'm, as Justin said, happy to pick up with you a conversation afterwards to try and explore more about what you've seen about how this looks a bit true transactional, and making sure that we're delivering what is needed for service users and the communities that we're trying to make a difference to.
Thank you, Chris. Let's check. We're moving on to see whether Mary, you wanted to add anything to what Chris has already said.
I think between Chris and Justin, they've captured it all. I just would wish to reiterate two key points. One is that with regards to numbers and the monitoring of things that we can count, our aim is 0, and it is ambitious. But we know we've got unmet need. So whatever measures we come up with quantitatively are probably going to get worse before they get better, as part of getting better. The second point is similar to the comments around infant mortality, is that much of the substance use agenda, and I will emphasize it's alcohol and drugs, not just drugs, requires us to do things with our wider population, not all of whom would see themselves as people who use services or need services. And those changes will feed through as well. So we couldn't put everything in the strategy. A lot of what's been mentioned, really, really helpful, is being picked up or will be picked up in the implementation plan. And I think that's where we'll start to see that we can address the nuance of the comments and feedbacks that have been really helpful.
Okay. Thanks, Mary. Okay, in that case, then I will note all of the comments and questions and things raised under this item, and we can move on to the next item. Just need to get approval. Well, can I just get check with members to see whether we can formally accept this item? Agreed. Thank you. Just checking I haven't missed anything. No, because we've sort of moved things around. The next one is the forward plan. Are there any comments on the forward plan? And I note that March already looks quite busy, but some of them will be, they won't be verbal reports. Some of them will be written updates and reports. So just wanted to just double check with the addition of an update from LMNS, whether that sort of timing wise would work, whether we might need to look at it again. Food to the next meeting. The next one, okay. Because it's quite a substantive item. Fine. If unless there's no other sort of comments on that, then I think in our pre-meeting we can just sort of work out where they go. Yes.
Just one quick on
we can get that amended because it might have been an error. Thank you. Does anyone else notice that they're not on there? Because we can just make sure everyone's is updated. No. Okay. Thank you. In that case, then just the next items are just the written updates, and they're just to note. Okay. That's item 16, and then same again with item 17. And then just want to check if there's any other urgent business. None. Okay. Thank you so much, everyone. And I'll call the meeting to a close. Thank you for attending and for presenting if you have presentations, and then also being part of really important, valuable discussions. Really appreciate everyone's time to meet in person. So thank you once again. And if I can just check that the streaming